Welcome to the Health Workforce Technical Assistance Center's webinar series. This presentation is entitled Developing Medicaid-Based Primary Care Rational Service Areas, and it was presented by Robert Martiniano on December 16th, 2015. Robert Martiniano is a Senior Program Manager at the New York Center for Health Workforce Studies, which he joined in 2001. Dr. Martiniano has an extensive background in health workforce research and program management, including 11 years at the New York State Department of Health. Dr. Martiniano is also an adjunct professor at the Sage College's School of Management, teaching courses in health systems and strategic planning. At this point in time, I'm going to go ahead and turn our event over to our presenter. After the presentation, you may ask questions using the chat panel on your screen. Make sure you send your questions to all panelists to ensure that they have an opportunity to be answered. Also, when the event ends, you will be directed to a short evaluation survey. So please, take a few moments to provide us with your feedback. Robert?
Okay. Good morning and good afternoon, depending on where you're calling from. Okay. So I just wanted to acknowledge a couple of things. This project was funded by the New York State Department of Health, and it's supporting the cooperative agreement between the Primary Care Office of New York State DOH and HRSA. And I also want to thank Dr. Chung and Dr. Damon for their work on this project. They're no longer with us, but they did a lot of work on this project. Okay. So I know that not all of you may understand what a rational service area is and how they're used, so I just want to give some background on that before I go into the nuts and bolts of the methodology. So essentially, they're used for a lot of different things in New York State or with the federal government. They're used for HPSA and MUA designation, MUA-MUP designation. HPSAs being health professional shortage areas. MUA-MUPs are medically underserved areas and populations. So what they are, they're geographic areas, and they're defined different ways depending on how you use them. So we'll talk about how they're used more generically, then I'll go into HPSA and MUA-MUP definitions. So they're areas that are defined by geography, by culture, by physical barriers. So for example, in northern New York, in the Adirondacks, you may have mountains or lakes that separate one rational service area from another. In New York City, it may be more like a park, a major roadway, or a major railway. So again, it depends on how it's isolated, how you want to define it. And generally, RSAs have similar demographics. So you don't want to create an RSA that has that has a real high-end in terms of affluent population, a very poor population, because their health-seeking behavior and their health outcomes and health status are going to be much different. So you want to try to both look at geography as well as the population. Okay. So again, as I said, HRSA uses them, and for HRSA definitions and for either HPSAs or MUA-MUPs, they can be whole counties, they can be aggregation of townships within counties in rural areas, they can be entire cities, or in urban areas, they can be aggregations of census tracts. Dr. David Goodman out of Dartmouth actually created primary care service areas probably at least 10 years ago now, using Medicare data and started looking at commuting patterns of Medicare patients to see how they went for primary care. And we actually used some of his methodology and tried to look at what he did in guiding us in doing what we did. So I want to start by saying why we focused on the Medicaid population for this work. In New York, we have an abundance of primary care providers when you compare it to our population compared to most other states. So, we realize there's a maldistribution of them, especially in inner cities, especially in more rural areas. But the issue seemed to be for us was access to vulnerable populations, low-income, Medicaid-eligible, people in rural areas, and people with limited English proficiency. So we thought that it was better to define these RSAs using Medicaid transportation patterns than the entire population. We also believe that a Medicaid patient travels differently than either Medicare patients or commercially insured patients for care. We know that in New York State, not as many physicians take Medicaid as they do Medicare commercial. So we believe that they would actually travel further for care, especially in rural areas, than they would if they are the other insured types. And probably more altruistic, or not altruistic, but well, we actually believe we had better information on physicians serving Medicaid right now than we do on practice patterns of all physicians. So it was actually data that we could use and look at. Okay. So I want to go into some of the methodology a little. So again, we use Medicaid data that from New York State Department of Health. We have access to all the Medicaid claims data. We looked at outpatient settings only. So we went through, that would include federally qualified health centers, or FQHCs. It would include hospital outpatient, private practice. We looked at primary care providers also. And what we did, because of our Medicaid claims data doesn't necessarily define primary care practitioners all that well, we actually took a practitioner and we linked it to the NPI database to get the setting definition. For primary care, we considered family practice, general internal medicine, general peds, and OBGYN. Then we also looked at evaluation and management codes. So we looked at office visits for either new patients or existing patients when they're the general visit codes. So once we limited our data sets to that, we started looking at zip codes. So we looked at the patient, the zip code of the patient, and we looked at where he or she was getting other services from in the location of the provider. And I'll go into this a little further, but then we linked the zip codes to each other based on a plurality of where patients went to care. So essentially we had a matrix that ended up being about 1,500 rows by 1,500 columns that looked at zip codes, each zip code, where they're from and where they're going, and linked them. So we did have some limitations. We decided that we did not want to make our service areas too broad. So our analysis was based on Department of Labor regions. And so if you were in one region, we didn't look at you if you traveled to another region for care. That way, we're not having people in Albany, getting care in New York City, people in New York City getting care in Buffalo for those, that 0.5% or less than 0.5% of that kind of care. We also use, we use Department of Labor regions a lot in our analysis because we're able to link other data such as Department of Labor projections, OES data, and other data that we have access to on labor, other labor data that we're able to link by region. So we looked at it from other different ways. And the other thing we actually did, we kind of rationalized our RSAs based on the HRSA guidelines, and I'll go into those a little further too. Okay. Okay, so New York State regions. So just for your edification, here are the Labor Department regions in New York. New York City's got the 5 boroughs: Queens, Manhattan, the Bronx, Brooklyn, and Staten Island, and then New York City, you can see Long Island to the right of that, which is Nassau and Suffolk County. And actually, the reason why we're showing you this is because we're going to actually refer to regions as we do some of our analysis. So let me tell you what we did. So we took, again, we used the practice patterns or practice commuting patterns of our patients. And what we did, we looked at the plurality. Where did the plurality of patients in one zip code go to another zip code for care? So we started with about 2,200 zip codes. We merged a couple if they were wholly enclosed in the other zip code or point zip codes. And from this analysis, we ended up with 279 RSAs. And you're going to say, well, the chart says 277, and that's true. So once we did our initial analysis, we ended up realizing, and we actually have maps at the end of the presentation that if we have time I'll go into and show you how we actually stepped through this work. We started looking at what the travel pattern showed us, and we realized we weren't following HWTAC guidelines. So some of the guidelines are you don't want to really have too large of HWTAs. So we actually had one HWTA or a number of HWTAs that span multiple counties. And when you think about that, it may be too broad. So even Dr. Goodman talked about that in his research, that sometimes when the HWTAs are too large or the RSAs are too large, you're using the localization, how they travel for care. So we wanted to limit that. We also have what HRSA calls the discontiguous RSAs, that you'll have a zip code, 2 or 3 zip codes spread by other zip codes so they're not touching each other. So we can't have that. The third thing we found was donut holes, where there'd be a zip code sitting in the middle of a bunch of other zip codes that are all linked. And again, we should show you on the maps how they look. And that's also something HRSA doesn't approve of. So once we looked at our initial set of the 279, we said, what makes sense, what doesn't make sense? And so we actually started looking at combining zip codes and splitting other RSAs so that our RSAs were more rational, for lack of a better term. And that's where we came with the 277. So that was our final set. And as you can see, they're divided by the DOL regions. And you can see that the number of zip codes in rural areas tend to be bigger in an RSA because we have more expansive. The populations, however, in urban areas were bigger. The other interesting thing I want to talk about was localization. And so localization is the percent of patients who find primary care services and other RSAs. And as you can see, if you look down, if you can actually read that on your screen, that localizations were much higher in rural areas than urban areas. And that's a couple of reasons for that, we think. One is, again, we talk about RSAs being bigger in urban areas, or sorry, in rural areas. So they're going to travel within that RSA. So in urban areas, they're smaller. Additionally, in urban areas, transportation is much more readily available, especially public transportation. So you could bounce in New York City between the boroughs and take an hour to travel and still go to another provider. So I think between distance and accessibility to transportation, it explains the localizations. So the next step was, once we developed our RSAs, we tried to define need. So we're going to go into that. And in identifying the need for analysis, we looked at research, we looked at HRSA rules, and we looked at current New York State Department of Health programs and looked at what data indicators have been identified as important. We also looked at what data elements might be available by zip code. So if we had something that was only available statewide, it wouldn't make sense. We did end up with one data element that was county, and we used that partly as a teaching moment, partly because we thought it was a good indicator. Once we identified our 10 data elements, and I'm going to go into them very shortly in the next slide, is we actually ranked them into quartiles. And again, I'll go into what that actually all means. Okay. All right, so here are our 10 indicators. So we divide them into demographic indicators and healthcare indicators. Okay. So essentially what we did, we created a deprivation score based on these 10 indicators. We ranked each of them 1 to 277 to account for our 277 RSAs, And then we ranked them into quartiles. So the first quartile got a score, the second quartile got a score, the third quartile got a score, the fourth quartile got a score. Then we added these scores together to get an overall ranking for the RSA. Now, interestingly, one of the things we actually looked at was how highly correlated these data indicators were. In our initial analysis, we actually had single female head of household. And when we ran correlations against some of the other indicators, it was so highly correlated that we were telling the same story with that data element. So we pulled it out and used limited English proficiency instead. So, you know, as you think about this, and as you think about it in your neighborhoods or in your states, you know, you've got to balance what indicators make sense for you. And I'm actually going to talk about that in a little bit. There are some plus and minuses for whichever indicators we use, especially when we look at urban and rural areas. Okay, so taking our 277 RSAs and again breaking them into the quartiles, this is how it breaks out by the different DOL regions. And as you can see, the urban areas, New York City and Western New York, which houses Buffalo, much higher number, much higher percentage of RSAs in the fourth quartile than any of the other regions. Though if you add the third and fourth regions together, you start getting, especially in the rural areas, a lot higher percentages. So again, this is an area where you can play with how you want to define need and determine whether you want to stay with a fourth quartile, where you want to break it into quintiles or something else, or you want to combine the quartiles to identify higher needs. Okay. So some of our findings, and I've explained some of these. Rural RSAs tend to be bigger than urban RSAs. We believe that Medicaid patients in rural communities tended to get services within their RSAs rather than moving to other RSAs like people in urban areas. In identifying need, community characteristics such as poverty, age, race, ethnicity was as important or more important than the healthcare outcomes and the healthcare status. And there were high-need RSAs throughout this state. Okay, so some of the limitations. Okay. Again, the initial RSAs, as I described, did not follow the current HPSA guidelines. Again, we had the donut holes, we had the discontiguous areas, and we had the large RSAs. We also didn't consider cross-state migration for health care. So we know along the Pennsylvania-New York border, there's a number of providers that people go back and forth across that border, same with Vermont and same with Massachusetts and Connecticut. So we didn't consider that. So especially along the borders, our RSAs may be artificially small or not actually following how care is really being accessed because we're not accounting for other patients coming in or leaving. There's also billing addresses. We noticed that when we were looking at the Medicaid information that some people could have actually put where they billed from, not necessarily where the patient got care. So we might have lost some of that information, and we might have had more centralized transportation patterns rather than how they really are going for care. And finally, the instability of the Medicaid patient counts that we know throughout the year patients come on and off Medicaid all the time. So we took a snapshot in time. So sometimes we may not have accounted for, again, them moving off and on the rolls. So some of our data and ranking limitations. So the variability in the data. So we use, as I explained earlier, we use demographic data that we've got off census data, and we also use our healthcare data. So census data is reported in ZICTAs, zip code tabulation areas. So especially in rural areas, you're going to have, with zip codes with really small populations combined. So sometimes that may not have, what word am I looking for? May not have easily linked to the zip codes that we use to create our RSAs. So we sometimes had to play a little with that information. And then, as I said before, the healthcare data was not necessarily broken out by zip codes. So the one data element we kept in that wasn't by zip code was mortality. But we thought that was important enough, and we just divided that using population by all the RSAs to get some counts within each of the RSAs. The other question was, did we use the right data elements as we were thinking about understanding need? So one of the things, again, we use race ethnicity, which if you think about that in New York State, New York City, urban areas like Albany, Syracuse, I'm spacing out, Buffalo and Rochester. So if we had taken that out and used something like population density, we might have gotten a different outcome in terms of having more rural RSAs defining need than urban areas. So one of the things we have to consider is what measures do you use and does it really identify need? And the other thing is how we rank. You could rank 1 to 277. We ranked them in quartiles. Again, it depends on sensitivity and how you think that's going to play out in your RSAs. The other thing we considered was the number. I've seen this done with 20 data elements, and sometimes that can overwhelm an area where 20 data elements could start bumping into each other and the correlation. So there's that balance you have to get. Okay, so why are we using these, or what would these be used for? We can use them to identify potential HPSAs and MUMs. In New York State, we have a number of programs going on, DSRIP, SHIP, and FIP, and they can be used for that in helping identify needs within those programs. We also have something called Doctors Across New York, and we have a number of other service-obligated placements outside of National Service Corps. Again, we could use it to define where to place doctors or other healthcare professionals for their service obligation, and also to access Medicaid utilization. One of the things we're planning on doing in the spring is actually comparing Dr. Goodman's PCSAs to our RSAs and see how they stack up. So that's something in the future we're doing. Okay. So I wanted to go through the methodology before showing you the maps, only because I think that sometimes the maps can bog you down in detail. One of the things I didn't talk about was what we used to do link our patient zip codes and our provider zip codes. We used UCI-Net. And UCI-Net actually is a software for identifying relationships. And so we treated the zip codes as if they were a node in a relationship and then linked. So the big circle is the big circle in the lower right is 2 counties or 2+ counties, and they're all going to zip code 10941, which is actually an FQHC in Middletown. So as you can see, for these 2 counties, which are Orange and Sullivan, everybody's going to Middletown. You also know up in the upper left, you see the arrow going to those single, I'll point them. Where are we? Okay. Oh, you guys can't see the pointer. So anyways, upper left, those are all single zip codes. So those zip codes, the patients in those zip codes stayed in that zip code to get services. So nobody came in, nobody went out. And then the other thing, as you see the lower left, the definitions, the thickness of the line describes how many people went from one zip code to another. The final thing is kind of in the middle where you see 2 clusters of zip codes being linked by a 3rd zip code. That meant the plurality of that zip code went to each site. That, let's say it was 30% went one way, 30% went the other, and the other smattering went other places. So we actually had to look at how the population was and other things to decide which zip code those people went to in determining our RSAs. Okay. So this is, again, this is that using the UCI net described how the zip codes look. So let's actually look at this in our initial survey, our initial RSA development. And this was the initial one. And as you can see, describing some of the things I've talked about are actually come through on this map. So if you look at the upper right-hand corner, and I'm red-green colorblind, so I'm going to guess on some of these colors. It's not very good. 12572, which is what color? I'm having people blue.
Actually, that one I believe is purple. 12572.
Yeah. So as you can see, that's sitting in the middle of a zip code and also discontiguous from the zip code that's above it, but they're traveling to the same place. You go a little to the left of that, you see 12443. Same thing. It's surrounded by an RSA, but it's standing alone. And again, if you go through the southwest border, you'll see 12771 being split, and two others being split from 12719. So again, looking at this, this is not, from a practical point of view, going to survive the RSA guidelines that HRSA has. So we had to look at that and do something different. Okay, and that's what we came up with. So again, once we looked at the guidelines, again, that big one, we split into two, and we tried to make them more rational in terms of linking them and removing the the donut holes. Now you will notice in kind of about a third left, there are two purple ones that are discontiguous. We didn't know what to do with those. It's actually two Hasidic Jewish communities that actually go to an FQHC in one of the zip codes. So while it didn't make sense, we decided to leave it there more for a teaching moment than anything, because it's interesting, and again, the zip code between it didn't tell us anything. It wasn't like the other two. And again, so we thought, again, as a teaching moment and also to kind of understand what's going on in the community, we would leave it there. Okay. All right, so I believe we are up to questions.
Thank you, Robert. That was a very informative presentation. First of all, really more of a point of clarification. Could you talk a little bit more about why you looked at those specific evaluation and management codes? Give a little context to what you were doing.
Okay. I don't look at evaluation management. So we had done some research, and Dr. Goodman, amongst others, had used those codes. It pretty much identifies a primary care office visit and they're called evaluation and management codes, and they're used to really define a visit to a primary care office. And again, other research has used it, and we didn't want to go too much off that process. Also, I saw, Alex, you asked a question about what software, ArcGIS.
All right, thank you, Robert. Next question. How do you use these RSAs for HPSAs, since you can't have a zip code-based HPSA, or can you if you create a statewide RSA map?
That's actually a very interesting question. So right now, HRSA only uses census tracts and counties and MCDs, townships, for that. We know that in the proposed methodology that's still kind of hanging out there, they wanted to go to RSAs and actually talked about Dr. Goodman's RSAs as an option. It's really hard to collect data at a township or at a MCD level, a township or a census tract level, especially for health indicators. So while it's not perfect, you know, we were thinking that we could do statewide, but you're right. In essence, we may not be able to use this unless HRSA says we can use zip code-based RSAs. And at this point, while I showed you only the map for the lower Hudson Valley, we did do it for the entire state, and we are preparing a report that will show them. Yes, and that answers, I guess, Alex's question. We are working on a paper that will outline this even more. Oh, sorry.
Anyway, thank you, Robert. Tell you what, here's a quick question. Hopefully you can answer this one too. Given New York State's Medicaid income threshold, why did you use the 200% of federal poverty level?
Okay. I actually used that, again, so in New York with the expanded Medicaid, we are actually up to 130 to 150, I believe, 133 to 150. And so the difference between that and 200 is probably not enough. But in other states that may not have expanded had expanded Medicaid, I think it would be a better indicator. So again, this was a place where I actually thought it was a better teaching moment and left it in at 200%.
Okay, next question. Does your claims data tell you the patient's zip code origin?
Yes. It actually tells us. Now, the only caveat with that is it actually sometimes tells us the county of who's responsible, or the zip code of who's responsible, not necessarily where they actually live. So we had to kind of play with that a little, but for the most part, it was fine.
All right, thank you, Robert. What indicators other than population density might be better to identify need in rural areas?
Yeah, so we thought about that, and I actually have done some research. So ED visits for avoidable conditions could be one. I've seen some research that talked about the time it took to travel to the provider. A couple of years ago, I would have used health insurance. Or the lack of. In New York State, it doesn't make sense anymore because I think, our last report said about 98% of New Yorkers have insurance, although in other states, it might actually be a better indicator. The other option would have been to drop race ethnicity, and I think that might have kind of rationalized things, put urban areas and rural areas on a more level playing field if we did that.
All right, next question. Were nurse practitioners and physician assistants counted as primary care providers?
No, they were not, but we could do that. And that actually, as I was thinking about that last question on data elements, that was something that would actually, especially in New York, would change the counts, because we know in upstate New York especially, there are a lot more NPs and PAs serving the population compared to downstate in New York City. So that's something that we could do that actually might change some of the need.
Okay, another question, Robert. In regards to avoidable hospitalization and ED visit rates, how did you define this? For example, for chronic disease conditions, for otherwise primary care visits, et cetera.
We used the AHRQ definitions, I think 4.5. Looking at, so we identified the 12 diabetes, I'm trying to remember off the top of my head, diabetes, respiratory, circulatory, and acute, and there's 12 that cover those. And so we use the AHRQ definitions. And then ED, we used DOH's ED rates, ED data.
Okay, thank you, Robert. One more question. You might have already answered this, but perhaps you could elaborate. What did you consider to be too small for an RSA?
A couple of thousand people. So we looked at population versus the size of the zip code. So we went population size versus geography, kind of thinking about the HRSA definitions of 3,000 to 1, 3,500 to 1. For designation, but also 2,000 to 1 for when a area is considered overutilized.
Here's a quick question. Is UICnet free software?
It's free to students, I believe. It's been so long since we've got this, but it's minimal cost. And once you get a license, you're able to use it ad infinitum. And they'll update it too. If you search for it, you can find it online. And trying to remember the gentleman, he's did a lot of research in social capital and he used it, but I can't remember his name off the top of my head.
Okay, once more to the audience, if you have any questions, please use the chat panel on the right of your screen to ask them. And please direct those questions to all panelists. With that said, Robert, what else, could you talk a little bit more about what else you have considered using these RSAs for?
I mean, initially HPSAs, again, we're thinking about identifying need. We're going to look at primary care capacity in general and for the Medicaid population, and try to figure out how they work. Again, we do have Medicaid data, we do have physician data, we can link to these. So we do have, we will have the ability to look at these issues, and again, it's something we're going to do in the spring.
Okay, at this point in time, I'm not seeing any more questions pop up. And by all means, if you have any more questions you think about later on, contact us via our website. But with that said, thank you for attending, and thank you, Robert, for presenting today. And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.